I request everybody except the host and chairperson to mute their mic. Dr. Neva, please mute all the mic except the chairperson and host.
Yeah. Other than the chairperson and host and the speaker, respectively, may I request all the other participants to please mute their.
Can I continue or I should stop?
9007610.
Okay, I'm continuing. Okay, this medicine were working because of the blockade of haloperidol, because of the blockade of dopamine, but it was seen that each and every patient of schizophrenia is not responding with this medication. So the scientists have thought that apart from dopamine, there are other neurotransmitters who are also responsible for causing this schizophrenia. Then they started acting on other neurotransmitters, and slowly they have found that not only dopamine, other neurotransmitter like serotonin is also responsible for causing schizophrenia. Then there was the discovery of serotonin dopamine antagonist, and even with the development of serotonin dopamine antagonist, okay, with the blockade of both dopamine and serotonin, it was found that some patient of the schizophrenia, mainly the catatonic schizophrenic patient. Am I audible?
You are audible, sir.
Yeah, and this other neurotransmitter like GABA is also causing the symptom of schizophrenia, mainly the catatonic schizophrenia, and that led to the discovery of this lorazepam in the management of catatonic schizophrenia. Apart from the dopamine, serotonin, GABA, we have other neurotransmitter like amino acid neurotransmitter, we have neuropeptide neurotransmitter. Nowadays, even the these neurotransmitters are there like nitric oxide. They are also responsible for causing many type of psychiatric illness. What is the beauty of these neurotransmitters is that they have given opportunity to the psychiatrists to speak something about biological psychiatry. Otherwise, once upon the time, it was thought that our mental problem is caused only because of psychological problem. And these psychological theories were playing a very important aspect, not only in our medical profession, but also in our social life. Even today, many laymen think that this psychiatric problem is mainly because of the psychological cause. Therefore, this neurotransmitter, this neurochemistry has given the window to all the psychiatrists to think beyond psychological aspect towards biological aspect and beyond genetic aspect. I still think that the word psychiatry is causing social stigma in our society. Many times you see even the WHO has changed the term, the psychiatric term, because of social stigma. For example, they have changed the hysteria into dissociative disorder or even conversion disorder. Likewise, what is my personal opinion is that it is a very high time that we should also think about changing the word mansik or psychiatry because it is causing social stigma. And let's think about changing our department to something like neurochemistry department, just like biochemistry department. I think that will definitely going to decrease the stigma associated with mental illness by changing the name of our department. This is just my personal opinion. Now I would like to give this floor to another chairperson, Professor Dr. Ravi Sake. He's a hospital director of Patan Academy of Health Sciences, and he's a president-elect of Psychiatric Association of Nepal. Over to you, Dr. Saab.
Thank you very much. Just hold on. Am I audible?
Yeah.
Yes, sir. Yes.
Just let me put the video also on, as I'm not getting it. Okay. Okay, good evening and namaste to everybody. I guess the PAN Western chapter deserves a big applaud for arranging this type of webinars every week. I really appreciate that, and it should be continued. And then I think we should listen to the presenter without wasting much time. I think we all understand the importance of this subject. So I think we should listen to the presenter. We all know Dr. Rao. And over to sir. Over to you, sir. We are
Thank you.
eager to listen to you, and then with your experience and with your expertise, I'm sure all the listener will be benefiting. Thank you very much, sir. Over to you.
Thank you. Am I audible?
Yes, sir.
Yeah. So, first of all, let me thank on this auspicious Wednesday when the PAN Western chapter is inaugurating literally a kind of show which is very helpful, useful for everyone. So, it is my pleasure to inaugurate this show with my brief message to you on the talk which I'm going to spend the next 30 to 35 minutes. If you ask me, I would have conducted about half day or 1 day workshop on the same Lochha, and but nevertheless, time is important for all of us, and this is a very unique starting. May I have the next slide, please? As you know, I have no financial conflicts to declare here. But as most of you know that I'm a clinician and researcher in psychopharmacology, and I work for all these companies. But during the next 30 to 35 minutes of my presentation, I don't think my bias would be based on my research and my affiliation to this research work. May I have the next slide, please? And to start with, my very humble thanks to Nepal Psychiatric Association. My dear friends are there as presidents right now, and the incoming president also. I know both of them, both of them, the chairpersons who have given a very wonderful. And to my dear younger brother, Dr. Professor Nirmal Ramachari, CP Sedan, and Dina Rai, Raviraj, and all the others who are present here. Thanks to you for inviting me. May I have the next slide, please? Now, I would start like a very simple lecture to start with. A professor of psychiatrist was addressing his postgraduates, somebody like each one of you were telling the students. He was asking them that a 24-year-old unmarried lady was brought in with severe EPS. He was getting treatment by a psychiatrist of the neighboring district with a generation of antipsychotics for the management of paranoid schizophrenia. Now, his questions are the following. May I have the next slide, please? Next slide, please. Nirmal, can you change the slide, please?
Dr. Devesh, please change the slide.
Yes. So these are the 4 questions. Because I would start with this introduction only to tell you that what do you mean by first generation antipsychotics? What do you mean by typical and atypical antipsychotics? How do you argue that the atypical drugs are themselves atypical? And what do you need? Why do we need so many drugs? I start the story with a very simple knowledge. When I'm a young resident, there were only 4 antipsychotics. Haloperidol, among the phenodiazines, we had chlorpromazine, trifluperazine, and thioridazine. And that's all. And towards the later part, we had pimozide. You would be, the youngsters who are listening to this lecture will be surprised. Now, that was really the first generation antipsychotics. May I have the next slide? I will, in the next, the first history, it's very important. I think my chairperson did start with this. The first molecule was an accidental discovery, and first FDA approval actually occurred in 1955, though it was originally used in 1952. That is none other than chlorpromazine. Then we had perfenazine, thioridazine, haloperidol, droperidol. Haloperidol, droperidol, triperidol, and other peridols are from the Janssen's lab. And pimozide, just now I touched about it. But now you see the right side of this slide. These are the ones which are ruling the world across by their usage by our psychiatrists. Clozapine in 1989 was FDA approved, and Hock and Palatin actually called this molecule as the true, real atypical molecule. Now they were using this, both these authors were using in comparison to the first generation molecules which was listed before. Of course, following clozapine, which had a very wonderful history, initial high and then low and then again high, risperidone, olanzapine, quetiapine, ziprasidone, aripiprazole, cetindole, paliperidine, iloperidone, and lurasidone. And now the three new molecules in this decade, I would say the immediate decade before us, was none other than brexpiprazole, cariprazine, and lumateperone. So these are the molecules which were probably different from the first generation. So for a simple understanding, any molecules which came after clozapine are typically atypical, whereas prior to clozapine are all typical antipsychotics. May I have the next slide, please? Now, why this story? There is no real consensus on atypicality, which I'm going to delve in the next few slides. No consensus of why they are called atypical, except how Palatin felt that the ideal molecule is clozapine. It had, for example, today, in general, we all agree that it should be effective as an antipsychotic, should have a minimal risk of extrapyramidal symptoms, should have only transient derivation of prolactin. Remember, prolactin is one hormone, which is differentiating. I'm going to show you that. And efficacy of both positive and negative symptoms. And I'm going to delve and show you from the evidence. And ideally more effective in the mesolimbic pathway and less suppressant of mesocortical. Originally, when this was started by the Sorenius and the three group as the neurotransmitter, the dopamine receptors, way back in the 80s, none of us knew that there is only multiple receptors of dopamine than one single receptor. D1, D2, D3, D4, and so on, the D1 family. And much later on, talking about today's topic, they were serotonergic family receptors. So efficacy in treatment-resistant schizophrenia is one, and ideally no TD or no NMS. And of late, we are now talking about 5-HT2A and 5-HT2C antagonism as a useful in the schizophrenia. May I have the next slide, please? Having said that, do we really have, and this is probably a cartoon which I'm going to show you, spend a little time. Today we know very clearly, for example, the D1 receptor mediated molecules are better than the D2 antagonists. This is done by none other than Kshitij Kapoor and Ho, who actually changed the dopamine hypothesis. When I was a student of psychiatry, we were taught that dopamine excess is the cause of psychosis. Today, we don't no longer think there is a classical hypothesis of excessive dopamine, which is the final output. But like our chairpersons talked today, they talked about GABAergic, glutamatergic, and the other neurotransmitter interaction. For our sake, let us now talk about Lochha in terms of these multiple neurotransmitters and their interplay. And I'm going to show you in the end that each atypical is different from other, but in terms of efficacy, let us see what is the evidences. May I have the next slide, please? The next slide, as I show, this is a slide I want to show the topic of the day. See, way back itself, haloperidol had probably the most potent dopaminergic antagonism. You find in relation to haloperidol, clozapine, as a weak D2 action. And risperidone, as you can see, is again a potent D2. Olanzapine is much weaker when compared to risperidone. And quetiapine, as you say, is a weak dopamine. Why did I show this? The original hypothesis of dopamine antagonism is gone. And as brought out in the introduction, 5-HT2A antagonism. Again, each of the molecule I'm trying to show you are different. Then came the hypothesis of 5-H22C. Again, as you see, haloperidol is a very weak 5-H2C. I want to show here, the higher the number, they are weaker. The smaller the number, they are more potent. And as you see, some of the molecules like clozapine might have a better histaminergic action, potent histaminic action, which is responsible for the sedation and also for the weight gain. Likewise, muscarinic action, they differ. The topic of the day, as take home as it is probably depicted in this slide and probably the next slide, which I will show in a colorful fashion. Yeah, next slide. Now you see so many colors. What does atypical molecules have? What are the receptors? I mean, I'm showing this as a take-home message. For example, you see right in the left the blonancerin, which can be considered as an atypical molecule only in today's world. You find that it has a D2, D3 action. Now the D3 action molecule, another molecule is amisulpride. Likewise, you see the other molecules quite colorful. What is important is some have more dopamine, some have more serotonin. And among the serotonin, as you can see between risperidone, olanzapine, and aripiprazole, and clozapine, and the lurasidone, which I depicted here, this is of course borrowed from obviously Stephen Stahl, but the take-home message is quite clear. No two molecules, if you see the colors, are alike. So that probably explains the topic of the day. The Lochha of the schizophrenia is covered by different molecules in a slightly different fashion. That's why they are different in terms of action. May I have the next slide, please? I would also put this cartoon and I would seem to throw it to you. Psychiatrists seem to know what schizophrenia is, but they don't know what is schizophrenia. This is told by none other than the most great psychopharmacologist of this era, John Kane. He wanted to emphasize that each schizophrenia is different and psychopharmacology is different, again, pertaining to today's topic. May I have the next slide, please? Now, a professor, as he asked, how do we diagnose EPS? How do we manage EPS? What is TD and what is NMS? I'm sure most of the doctors who are attending here know, but I'm trying to now differentiate between mesocortical and mesolimbic on one side, and supersensitivity versus atypical actions of the antipsychotic on another by the NMS. May I have the next slide, please? For example, EPS, the most potent D2 blockade actually causes acute dystonia. They cause akathisia. They also cause drug-induced form Parkinsonian symptoms. And finally, this group is likely to cause tardive dyskinesia. So this was the differential between typical and atypical. Not that atypical molecules, like some of them like risperidone, they are powerful D2. That's why they can also cause acute dystonia, though much less when compared to haloperidol, which was always considered as a gold standard molecule. But akathisia is again quite common with aripiprazole and with some of the other molecules it is present. But there are other molecules which do not have akathisia, like olanzapine, clozapine, and quetiapine. They are less likely to have. And can I have the next slide, please? Now, the differential again, the blockade actually leads to these three differential side effects, which again differs between the dopamine cholinergic balance and the acute dystonia occurs because sudden blockade leads to cholinergic blockade. May I have the next slide, please? As I go, I think dystonia occurs with most neuroleptics, especially the first generation. The first symptoms of dystonia occur during the first week and intermittent. So this differential is again evident in the different molecules of atypicals. May I have the next slide, please? Again, the greater differential of dystonias, as you can see, apart from the potent D2 action, is the females are likely to have much more. Children and teens are likely to much more. Alcohol and cocaine can have more. Again, I want to show that within the brain there are multiple neurotransmitters and drug-to-drug interactions, and they lead to this kind of side effects. May I have the next slide, please? I just want to just refocus on this presentation of multiple. Though they are rare in the atypicals, some of them are reoccurring. For example, cariprazine and lurasidone seems to have a peculiar oculogyric crisis, and that is reported in the literature. May I have the next slide, please? As you see, I think we need to have a good neurology, and as this forum in which I'm participating are showing typical and atypical movement disorders, I thought I'll just show to each one of the group here that involuntary movements, especially in the management, we need to remember that the benzodiazepines as brought out by the chairperson, promethazine, for example, or benztropine can be of real help in covering these kind of symptoms. May I have the next slide? So our brain is full of lot of neurotransmitters, and each of the side effects is related to some kind of a differential of the action of these Lochha molecules, which each molecule has different Lochha of neurotransmitters and LOTA or whatever. So that some molecules are much more and some molecules are much less. And this is the take-home message of number 3, that akathisia, for example, can occur with even SSRI sometimes, but it's more common with atypical antipsychotics. Among them, aripiprazole is one, and sometimes risperidone, and the newer molecules, cariprazine, also seems to have mild akathisia at higher dose. May I have the next slide, please? I would not spend too much time on the akathisia, but I'll go to the next slide because I just want to focus on the topic of the day on the neurotransmitters. One of the reasons of akathisia consequences apparently is that it might lead to a lot of increases suicidality on one, increases violence, and apparent worsening of psychosis is attributed. Sometimes it's misdiagnosed and they keep on pushing haloperidol injections in the olden days. So I would suggest that we need to go much more aggressively on that. May I have the next slide, please? Try to understand that benzodiazepines are the source. So here we are attacking the dopamine cholinergic imbalance by adding a third molecule of GABAergic system, which actually works. But if you really want to see some of the newer atypicals, especially clozapine, for example, does not have akathisia at all. The reason is inherently within this molecule, there are so many receptor action, and I'm going to spend a minute or two about clozapine before I finish, so that you take home messages. Clozapine is the real atypical molecule among the others. May I have the next slide, please? So this again is how to treat in akathisia, which I don't think I need to teach you, but I said I have to keep this graph only to show that anticholinergics, GABAergics, benzodiazepines at different dosage, and propranolol are probably the treatment of choice for akathisia. May I have the next slide, please? Now I come to the drug-induced EPS, I would say, Parkinsonian symptoms. The difference is they are potentially related to the dosage and the potency of the molecule. So low frequency, high amplitude, jaw tremors, all occur at some point of time, but anticholinergics, here we have brought, apart from dopamine, serotonin, GABAergic, glutamatergic, now we are bringing the anticholinergic as an important component of our pharmacology management. That means our brains need to be attended on this. May I have the next slide, please? And finally, tardive dyskinesia, according to this Kohler-Cohen diagnostic criteria, there should be at least 3 months of cumulative use of antipsychotics. And mind you, atypical molecules also cause. We have these case reports reported from risperidone, from ziprasidone, from aripiprazole, but some of the authors do comment that it is probably a collective usage of the antipsychotics, which leads to tardive dyskinesia. I brought this issue that tardive dyskinesia etiologically is a slightly different. It was definitely considered to be supersensitive reaction, but really we don't know what is the cause at this point of time. But what works today is the not the triacylphenyl or benchtropine, but tetrabenazine and the newer class of the benazine classes, the three other molecules which are approved by the US FDA, are the ones which are tardive dyskinesia. But luckily, after atypicals, I think the number of TDs have really come down. May I have the next slide, please? Well, again, this I don't think we'll have time to present, but suffice for us to understand that we are actually attacking using tetrabenazine as a molecule available in our subcontinent for the usage of treatment. May I have the next slide, please? And this is probably the most painful side effect, the tardive dystonias, which I thought I'll spend a little time on this, only to further emphasize that the GABAergic pathway is one pathway which is probably underutilized in the etiological cause of schizophrenia. But in these kind of movement disorders, we know this is the cause. May I have the next slide, please? As we move forward, certain things are probably take home for the youngsters. I thought one slide would be useful. If psychosis is under control, lower the dosage. Switch to clozapine is one of the options for tardive dyskinesia, or switching to another milder version of SGA, like, for example, olanzapine, quetiapine, adding an antidyskinetic drug. The newer drugs, tetrabenazine and their class are probably, but in our country now we have started using one, as we use deep RTMS and deep brain stimulation using a kind of a stimulator automatically. But there are obviously they are the last resort, deep brain stimulation. But in some cases, increase of dosage of antipsychotics also helps immediately. May I have the next slide, please? So my story is going on to show that I use psychosis as a model. I use antipsychotics as a model to explain that our brain has probably multiple neurotransmitters. One of the symposium on clozapine during the All India conference, I was presenting. I was commenting saying that in the brain, all neurotransmitters are present, some more, some less in each one of us. And that's why each of us might differ in the presentation of psychosis, but also response to atypical antipsychotics. That is partially true, right now evidence-based. May I have the next slide, please? This is probably the data which is coming out, the tardive dyskinesia. Those, but they are much less. They have to be very careful, especially in the litigious world. May I have the next slide, please? Now I go to the other part of the treatment algorithm, which is broadly how to handle the prevention part of the TDs, which is very important. To begin with, a patient who develops akathisia on the second day is most likely to develop TD. That is one of the young people, women, and the people with concomitant cannabis use are more likely to have. So this is the treatment algorithm for the tardive dyskinesia. May I have the next slide, please? I thought in our confusion, we should not miss a lot of things. Almost all these are related to a combination of neurotransmitters. And if you see the symptoms wise, there is a dopamine circle, there is a GABAergic circle, there is a cholinergic circle, there is again within the circle, which we should not forget, intermediate neurotransmitters, which probably play a role in other areas like the cyclic AMP and all. So suffice for us to conclude today, a complex disease like psychosis of schizophrenia probably is multifactorial, like the chairperson has commented in the beginning. May I have the next slide, please? I'll spend a few minutes in closing my arguments on the other positive side of the evidence of the molecules and how they differ from each other. May I have the next slide, please? So NMS is one which is should be kept by the youngsters at least. That NMS, whenever the patient presents with EPS, with autonomic imbalance, especially high temperatures, and sweatings. Please remember NMS is one of the important, and NMS seems to have a much more complex etiological factors. I think suffice, I just thought I would project this as an important variable of the neurotransmitter complexity which we are learning today. May I have the next slide? I thought for the sake of thing, in the good old days, the high potent neuroleptics, long-acting neuroleptics, the depot preparations, especially of orphanagine, etc., and age below 40 years, male gender, and any organic prior brain disease are the highest risk factors for the NMS. So remember this, and this is an acronym, as you can see: agitation, dehydration, exhaustion, malnutrition, non-schizophrenic illness, lithium use, and past history of ECT all seem to have potential to kind of accentuate the NMS in some predisposed individuals. May I have the next slide? The complications today, probably when we talk about all the antipsychotics, we should not forget that some of this can lead to a lot of other complications unrelated to psychiatry alone. Keep that in mind. We had a very strange case in the recent times who had a cardiac arrest following giving an atypical antipsychotic, and we went on to discover that there was a WPW syndrome before, which we missed out in the early ECG. May I have the next slide, please? So broadly, I will go to the next 2-3 slides to just close my theme of today's, that the brain is such a complex thing that we need to take care of not only the proper psychopharmacology, but also our psychotic patients do have hydration issues. They have a lot of other medical issues which we miss out. Deep vein thrombosis can occur, which is unrelated to our neurotransmitters. But specific measures for the management is DA agonist for the NMS and muscle relaxants. And of course, ECT does help. May I have the next slide? Can I have the next slide, please? This is further continuation of NMS, which I think we should not waste our time. But I have a further 2 more slides to explain to you. May I have the next slide? Next slide, please. So ultimately, this is the take-home message for all of you. How to choose a molecule, how to choose an antipsychotic is one, apart from the efficacy. Here I'm putting in terms of side effects, the molecules differ. Previously, I showed you the receptors. Now I'm showing you side effects. For example, clozapine has the highest and slide, please. Wastuna. So the last 3-4 slides are I might focus on the other things which are again not part of the neurotransmitter hormones, but they are related to the insulin levels and insulin causing a lot of other things. So the atypicals are one of the problem is metabolic syndrome, and I'm just trying to explain based on the hormones again. May I have the next slide, please? Next 2-3 slides is related to the weight gain mechanism. Again, is related to one. Maybe I think time has come for us to understand that this is one area which we understand quite well. I stop here. I just want to show you that even in the weight gain, you have D2, you have 5H2-2C, you have H2-2A antagonism, you have H1A, 5H2-1A antagonism, we have histaminergic antagonism, etc., etc. I might close with my closing remarks telling you that brain and the body is full of lot of lochas, and each lochas or each groups of hormones are responsible for a group of response. Thank you very much. We can close these slides right now, and I'm here to answer a few of your questions during the next 5-10 minutes, please. Thank you very much once again for all of you for the patient listening.
Thank you, sir. That was a wonderful presentation. And I thank you again for giving such valuable insights. Now the floor is open for questions if any of the participants has any queries.
Yeah, Nirmal, you can comment now. I think you are waiting to comment.
Okay. I think Rabi, Dr. Rabi,
I think there's a question from Rika Rizal. Nirmal, there's a message.
Yeah, I could see that. Antipsychotic induced dopamine supersensitivity psychosis.
yes.
How to diagnose in the clinical management. Technically, it is just a clinical thing that patients during the first 2-3 weeks who show severe EPS. Now we are talking about sensitivity for the mesocortical tract. That can be very well identified. Likewise, how do they differ? They are more likely to have oculogyric crisis or acute dystonias. Acute dystonias and akathisias are probably differential. And also, if you watch them for the next few months, they are likely to develop tardive dyskinesia. But apart from that, the clinical factors are younger people with alcohol and cannabis. Today's world, the more common use. Then tobacco smoking, tobacco co-use, co-addiction. And finally, these patients have a differential response. Normally, John Kane also thinks that within the first 4 to 8 weeks, if there is no good response, this patient is not likely to be responsive. So that is another clinical variable which we can differentiate compared to others. But as you see, the dopamine supersensitivity hypothesis had its heyday in 60s and 70s and 80s. But in late 90s onwards, now we understand that there are too many hormones which can be interplay, and what we know today is not complete. Hope I answered that question. Ravi?
Ravi, sir.
Ravi, sir.
Okay. Thank you, Rao sir, for your wonderful presentation, and thank you all the listeners for the passionate audience, and then the even wonderful questions. I don't have any questions, but it's just my sharing my thoughts about the way the antipsychotic has evolved in the past, let's say 70 years, no? 60, if you call it 60 years, let's say. When the first dopamine agonist came, there was a big optimism, feeling that everything would be taken care by this dopamine antagonist. But slowly we realized that there are other neurotransmitters that are also important, like serotonin, and now we are known many other things like glutamatergic. Even now we are talking about many other neurotrophic factors, and then I'm sure that there will be new things that will be evolving. Not just the chemical things, but maybe many other things. Already there is a huge branch that is upcoming, like immunohistochemistry, immunological things are also coming up, and I'm sure in the time to come there will be even more newer intervention and newer treatments. So but still we have to go by the evidences. This is the evidence that we have at the disposal, and we should try to do the best of we should add up the best evidences that is available right now. but what I feel is that the neurochemical imbalances will not alone answer all the psychiatric problem or psychosis, let's say. That's just my general comment, sir. And
Your comments are okay, Ravi, but I might add just one point to that.
sir,
What we
please.
thought about schizophrenia uh, 70 years back or 50 years back is different from what we are now considering, because
Exactly, sir.
have
Exactly.
we have much more technology. And the other thing which is important is, I think the newer molecule, lumateperone, is probably one I'm looking, because that is totally different in action. But as you said, we have to evolve further in the next 2 decades. The younger generation would have much better molecules than we, the old generation psychiatrists.
For sure.
That's one. And may I wish that these Wednesday meetings will be much more kind of a thing. I started with, I would say, auspicious, as you can see in my background, Lord Vishnu's day. Wednesday is Lord Vishnu's
Yeah,
day, and
I noticed that, sir.
I think you will have a
Thank
very
you,
nice
sir.
time. And I'll be
Of
joining each time whenever I'm available with you, just to listen to people like you all the time, and may God bless you all the time. And you come from a kind of pious land, and I'm thankful for all the seniors who are here. I know some of you, I have met you in the Kathmandu at least many a time. So thank you very much for this opportunity.
Thank you, sir. Thank you, sir. I think we have a couple more questions.
Yeah, I
First
can
is
answer
from
that.
Dr. Ashish Datta.
Yeah.
I'll let Dr. Ashish Datta to go ahead and ask this question.
Yes, Ashish.
Good evening, sir.
Yeah, good evening.
Thank you so much for such an insightful presentation. And during our clinical practice, we quite often come across these complications related with movement disorders. And many a times as psychiatrists, we find it quite difficult to delineate which one is because of medication and which one is part of independent neurological disorder. And more often, I find this issue difficult to delineate in cases of idiopathic Parkinson's disease, when elderly patients, they are under antipsychotics for a long time, and they simultaneously develop these Parkinson's disease related issues, which neurologists, they tend to diagnose as idiopathic. During those times, we find it particularly difficult to handle it, actually manage it. So could you please throw some insights into this particular matter? As like early psychiatrists, we have just begun our career in psychiatry. So how do we approach such issues, especially in elderly patients who have idiopathic Parkinson's disease?
That's a very interesting question. The great differential is the age of onset. As we know, most psychosis, especially the schizophrenia psychosis, starts in the second decade and third decade. So that is the time when any movements occurs. It is this. The exceptions are only Huntington chorea, where the age of onset can be around 25 to 35, and you have a family history of autosomal recessive disorder. But you are right. Sometimes, if the first time psychosis occurs at 45, 50, and there are issues which we cannot the 45 or 50 first time psychosis, you start with risperidone, and there is a severe EPS, and you can't explain based on 2 milligrams also. That is how probably sometimes clinically you can catch. But obviously today's world, I think once neurological side effects, neuro symptoms occur, anyone about 45, 50, think of organic. And you're right that the drug-induced psychosis, cannabis-induced psychosis, this is one of the groups which have more severe EPS or differential EPS. So sometimes even for senior psychiatrists or senior neurologists, it's difficult to differentiate what is idiopathic Parkinson's versus drug-induced. I had a very peculiar case recently when patient was only on SSRI, initially changed to SNRI, and developed tardive dyskinesia. And there was no exposure to antipsychotics. So these are some of the probably markers. They are exceptionally rare, but they can happen. But your question is very well taken. I think is by repeated things. And I think in this group which I'm following with, which Nirmala started, we are now getting a lot of cases of movement issues. I think we learn from each other during this, being in the group itself. Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir. I think we have time for one last question from Dr. Achyut Acharya. I'd like him to go forward and ask this question.
Namaste, sir.
Namaste, namaste.
Good evening, sir.
Good evening.
Sir, so with first generation antipsychotic having side effect of EPS and second generation antipsychotic with metabolic syndrome, and as per global burden of disease 2019, 5 million deaths are related to obesity and 4.3 million by heart-related disease. So it is always a dilemma which to use when. So can you clarify on that? So what to use for, as we are looking to use it for a long time. So sir, which will be the better option, sir?
Which one among the which one you are among which molecules you have a choice? Hello, what are the choices you are asking?
Sir, with
Okay.
so with first, sir, shall I continue?
Yeah, you can continue. Which molecules you are using?
Yes, sir. There is always a dilemma between first generation antipsychotic having side effect of EPS and second generation having a side effect of metabolic syndrome.
Yeah. See, the point is, it is well understood that the second generations are superior to first generation. Almost most studies and 4 more studies have shown that. And I've shown in my single graph, but I didn't want to show it. This is not a lecture on the superior. But you are also right on metabolic side effects we need to monitor. And prolactin is the third one. That's why I said all the 3 are important. But second generations are superior. For treatment resistance, of course, clozapine is the best. So there's no doubt about it. On treatment resistance, clozapine and clozapine augmentation. But when it comes to the first generation, I think hardly we use nowadays in our country. Definitely not haloperidol, which has toxic effects. Okay?
Okay, sir. Thank you, sir. Thank you very much, sir.
Okay. So I think we have finished the webinar on time. In fact, we have 6 minutes left for any discussion. This webinar, I was inspired by the Indian Psychiatric Society's, I think, I don't know which part of Indian Psychiatric Society have started Thursday Musing. So I found it very, very inspiring. Actually, whenever I have time, I watch that webinar, and I've learned a lot. And then I thought, why not we also begin so that our, especially the residents would benefit. Being the first one, and in a short notice, whatever participants we had today is very inspiring. I know in future, like the chairperson thought that it is weekly. It's not. We'll make this webinar monthly, and in our next talk webinar will be by Dr. Anupam Pokhrel, all the way from Australia. He has already accepted our invitation, and similarly, we'll plan for the year-long webinar. I'm really thankful to. I have no words to thank Dr. G.P. Rao sir. I know even now he was attending some other function, and he agreed to be the inaugural, speaker in this inaugural webinar. I have no words to thank you, sir. You have always been so supportive to me and to the fraternity as a whole. And I hope that our bond will continue and even go further. So with that, I think it's time to say good night. Good night, everybody. Thank you very much.
Good night. Good night, everybody. And congratulations, Nirmal. Once again, congratulations, the Western chapter of the PAN.
Thank you, sir. Thank you.
Good night.